Welcome everyone to the symposium. Whilst we're just giving people a few minutes, if all the cool kids at the back could please come forward. We're likely going to be an intimate crowd, so do come forward. We really encourage you to come forward a little bit, and maybe we can center ourselves in the middle so we can make eye contact as we talk to you guys. Okay, so let us start. Please come in if you're, yeah, putting him on the spot. So welcome everyone. I know it's been a long day, but this conference has been really exciting. So we are shifting gears to speak about HIV and obesity. And this symposium is really looking at three aspects of it. So this will be an interactive session, so please feel free if you've got any questions, just put up your hand and we can talk about it. So just to go through what today is about, we'll have three speakers. So I'll be both your chair and a speaker. So my name is Nomathemba Chandiwana. I work for a research unit, Ezincha, that's part of WITS. And some of the exciting work that we do is we do HIV work, but my area of interest is the overlap between HIV and non-communicable diseases. And I'm joined by Francois in the middle, and he is the executive director of our unit. Also comes with a wonderful CV of lots of things done within HIV, all areas of HIV, and also our unit has been moving towards HIV and non-communicable diseases. And we have someone joining us who's not from our unit, but is from UCT, Dr. Mone Katz, and he'll be giving a talk on HIV and cardiovascular disease. So apart from his many talents, which include playing the guitar, so please Google him if you're wondering what I mean. He's doing some work around cardiovascular disease and people living with HIV. So the symposium, just to give you an outline, we'll have three talks. And the three talks will be looking at HIV, using HIV as a model for obesity care. And that's really setting up the next two talks, one around HIV and obesity, and the last one, HIV and cardiovascular disease. So I will start with my talk. These are my disclosures. I wish this was, I think this will be better, yeah. So if you look at the pictogram behind you, this is looking at a heat map that's looking at both HIV and obesity rates. So while we understand where HIV is, obesity is similarly, and we're seeing this in emerging markets. So the BRICS countries, so if you're looking at South Africa, India, Brazil, and this makes sense as we're going through an epidemiological transition where people are moving from having different types of food, relatively moving from poverty to being in middle income countries. So we're seeing growing obesity in regions where we see high HIV prevalence. But weight-related disease has now overtaken both HIV and TB in causes of mortality and morbidity. So in a country like South Africa, where we really looked at HIV being the leading cause of death, we're now looking at type 2 diabetes among Black South African women being a leading cause. And the annual deaths related to obesity and overweight are now 4 times more than HIV globally. So I think we come from a communicable disease, and we focus on that, but non-communicable disease is a surge that we need to prevent. So this is looking at GDP and obesity HIV trends. So if you look at those circles, it's showing the epidemiological transition. So in most where this has been looked at, so those bubbles are looking at obesity and HIV. So on your left, on your right, my left, it's showing the changes that we see. So often we find women having high obesity rates than men, and then we have children. So if you're looking at South Africa, it shows us what epidemiological transition we're in and what to expect. This is also helpful because often we see things in time, but we also should see it as a trend and where we're going. But as we're looking at obesity, I think you'd be surprised to know that half of all people living with overweight and obesity live in just two countries, which is South Africa and Mexico. So we tend to think of this being a high income issue, but actually some of the highest rates of obesity and childhood obesity are on the continent. So of the top 10 countries with high rates, all of them are in middle and low income countries. And you'd be surprised, even countries like Zimbabwe, for example, has got some of the higher rates of childhood obesity on the continent. South Africa has got the second highest rate. And we see this obesity should be seen in the same context as malnutrition. For people who do see patients or people living with overweight and obesity, you'll find it's a parent with overweight and a child with stunting. So when we look at overweight, we should look at it through that lens that it's malnutrition. So this is a map that's looking at HIV and life expectancy across continents around the world. And life expectancy has, for people with HIV, is roughly the same as people without. But what you may not know is that people living with HIV have got 16 years fewer good health, years in health. So what we've done, we've changed HIV from being a communicable to a non-communicable disease. So the reasons why people are living less, cardiovascular disease, so that's going to be the reason why we have Dr. Katz speaking today, metabolic disease, which includes obesity and type 2 diabetes, certain cancers. So obesity is linked to about 200 diseases. So people who play Jenga, if anyone who's familiar with the game, it's blocks. So at the bottom, it's obesity. And on it, we can add about 200 diseases. So working on obesity, it's not just for aesthetic reasons, but we're reducing our risk of a lot of other diseases. So the metabolic complications of HIV and obesity. So we've got obesity being one of them. Francois will speak a lot about that. And we've got some clinical evidence, particularly from our unit, speaking about that. We've also seen insulin resistance and type 2 diabetes. MASLD, which is metabolic associated liver disease. That's quite, it's about 30% in people living with HIV. We almost have no African data. And we'll speak about cardiovascular disease. But I'm just giving you this to show you that there are a lot of metabolic complications of HIV. We're just touching on two today because of time. So this is the POPI cohort that's based in the UK. They followed up people living with HIV for quite a bit of time. So the average age is between 15 to 20 years older than the average African living with HIV. And what we're seeing in this cohort, they had about 1,000 people, and they looked at what are the diseases that they have. So most people, and the median age was roughly 52, and they saw that people had up to 6 non-communicable diseases. So when we look at obesity, cardiovascular disease, we're looking at multimorbidity. So we're seeing multiple diseases that are living, that are in one person. But you'll find that HIV is being treated well, but at our clinics, do we have BP machines that work well? Do we have scales that work well? So it takes about 5 to 7 years for someone to be diagnosed with type 2 diabetes and to get treatment that they need. But with HIV, we've been quite good at it, you know. We've got algorithms, we've got nurse-based care. But when it comes to non-communicable diseases, we still have a long way to go. And age is an important factor. So obesity does affect everyone from childhood to the elderly. But we see with increasing age, we have non-communicable diseases. This is something that I'm quite passionate about, which is menopause. It's something that we're not taught at medical school as clinicians, and we are now finding women living with HIV entering menopause. And this happens between 8 to 10 years earlier than women without HIV. And apart from that, I think when we think of menopause, we think of it as the estrogen effects, you know, the physical dysfunction, cognitive impairment, and so forth. But it's actually a point of cardiometabolic transition. And in Southern and East Africa, where 60% of people living with HIV are women, this is something that we have to look at, that in this transition, we're seeing things. So if you look at the concentric circles, so one being menopause and its issues, and then HIV and its issues, and what's in the middle. So we are then seeing women who are younger, entering menopause, so that cardiometabolic transition. So if a woman comes to your hospital, etc., with chest pain or something else, most people would not think of a cardiac issue. So this is just to make you aware. So I'm going to give a country example of South Africa, since we're here, and also it's a country that has the most people living with HIV. These are statistics that we know all so well. But what you may not know is the statistics when it comes to obesity. So this is data from the World Obesity Federation. They've got an atlas that's released on World Obesity Day every year. So actually every country in the world is there, and they rank it up. And they give you data of each country, and is split by male, female, and they also have some pediatric data. So what we're seeing in South Africa, apart from just having high rates of obesity, so we're looking at about 2/3 of women, 1 in 10 men, and some of the highest childhood obesity rates in the world. But if you see the line, it's hard to see the numbers. So just to give HIV as an example, where we have about nearly 8 million people living with HIV, obesity at the moment, we're looking at about 24 million South Africans. And that is expected to rise by 10 million people in the next decade. So I'm just putting it to you that, you know, we are, I think as a HIV community, we've really, really looked at HIV. But when it comes to non-communicable disease, our response has been flaccid at best. And this is actually what is causing shorter lifespans in people living with HIV and without. And particularly the African continent and other middle-income countries are particularly vulnerable. So some of the parallels between HIV and obesity. We've got similar threats to public health. We've got available but underutilized interventions. So right now, and Prof. Fente is going to speak about some of the drugs available. They are expensive, but it's almost like we are going back to HIV before we had drugs available. And these drugs are now rivaling bariatric surgery in how they work. Stigma, both within the medical community and also among ourselves. So if you think about it, what do we say about an overweight individual? What language do we use for children? And it's the same stigma that people have when it came to HIV, even now, 4 decades into the epidemic. So weight-related stigma, you're less likely to get a job if you're overweight. You're less, even if you do, you're not going to get paid as much as someone of a different BMI. So weight stigma is a big issue. And you're less likely to go to healthcare professional. So obesity is one of the only diseases that we think Virgin Active will fix, right? So what do we do on January every year? We're just like, I'm going to work out more, eat less. But the evidence we have is that moving more and eating less does not necessarily help you with obesity. So just like any other chronic disease, we've got more things in our toolbox that we should use. And just like HIV, there are also structural and environmental drivers of obesity. So in your community, do you feel safe working out? Can you walk at night? Do you have time to do so? What's quicker for you to do? A quick meal, Uber Eats? What is more affordable? Is it more affordable to have magwinya, which is a fat cook, which costs 2 rand, or for you to have a healthier choice? So 40% of the average South African's diet is ultra-processed food. We also have low diversity in our food as well. So it's not just, so looking at HIV, it's just not like you have the drugs and the people will take them and everything will be okay. We've got a few things in our toolbox. So I'm going to go through these slides quickly as I finish up my part. Is a few lessons that we've learned from HIV that can be used for obesity. So the first one is the cost of inaction. I think I've laid it out, the issues that we have, but we're not doing anything. So again, South Africa being an example, we delayed in getting antiretrovirals available for people, and this resulted in about 300,000 people getting HIV, 300,000 deaths and 200,000 new infections. So when I showed you that, that graph, which is this one, the cost of inaction, so dark blue is the Africa region, and the bottom we're looking at different diseases. So if we do not make a change or do something around it, we will really see obesity double within the next decade on the continent. So this gives you, so again, this is from the World Obesity Federation. This is important. So the cost of inaction is high. But what do we have available? Our healthcare system cannot take all the complications of obesity and its complications. So lesson 2, reducing stigma. This is very important. I think often we look at biomedical approaches to fixing people, right? But as we are reducing stigma, we also need to reduce weight-related stigma. How do we make our healthcare systems available? Even the language that we use. I think people-first language, we'll use things like, we'll say someone living with HIV, but we'll say an obese person or morbid obesity. So again, using people-first language is important as we are looking at obesity, reducing obesity-related stigma. Access to treatment. This is showing what has happened in the HIV continuum. We have so many drugs available, and also innovation, research, and so forth, and affordability. Right now, TLD costs about $75 per person per year, which is so affordable compared to drugs that we had before. So when it comes to obesity meds, we need to have the same kind of access. The other thing is community mobilization. I mean, for me, being a researcher and a scientist, we really benefited from the community standing up, right? To say we need these drugs. So as we are going to look at non-communicable diseases and obesity, we also need to take the community with us. Because what do? We come up with these great guidelines and so forth, and then we say, community, come, do it for us, right? But we actually need to take our communities with us, because we don't always have the answers and we always don't understand. And the last thing is public awareness and messaging. So anyone who has been a person in the world, you've seen some sort of messaging around HIV, around PrEP, around so forth. But when it comes to non-communicable diseases, or obesity, or hypertension, or type 2 diabetes, have you seen any messaging that is appropriate for you, for your communities? So that was one thing that really worked well when it came to HIV, and we can use the same thing when it comes to non-communicable diseases. So HIV does offer a blueprint, not for all settings, but I think certainly for settings such as ours, it could be. We can use key policy levers that we've used before, strong activist movement, and also have systems and create demand. So this is just showing a roadmap for access when it comes to some of the drugs that are on the pipeline, GLPs. Again, this will be talked about in a little bit more detail. So in summary, as I hand over to Prof. Venter, obesity, like HIV, and its complications are significant, and they're growing. And they're a growing threat, not for the Americans, not for others, but for us, middle-income countries in particular. Both HIV and obesity have effective prevention and treatment tools, but we also need to accelerate access so we don't have the delays and we learn from lessons of the past. And the success of HIV programs, I'll give South Africa as a prime example, included few key things: community engagement, activism, science-based policy. This can provide a blueprint for certain countries as we look at non-communicable diseases. And we also need to have a research agenda that's appropriate. So I went to the International Congress on obesity, which was in Brazil. It was really exciting. But in there, I think there were probably 5 Africans, in the whole Congress. So I do think we do need a research agenda that's appropriate, because there are certain issues that would be difficult in other settings. A prime one being, if you were to lose half your weight in 18 months in an African setting because you're using these great drugs, what does that mean? When we have weight-related, we've got stigma when it comes to HIV. So we do need to have a research agenda that is appropriate for us. So I'm going to hand over to Francois, but before I do, are there any burning questions before we continue? No, okay. Oh yes, there is. Please stand up and introduce yourself. Yes, use a community voice.
Just some clarity. I think in your very first slide, you mentioned that people living with HIV, they're 16 fewer years in good health. Would you please clarify that? What do you mean? Yeah, thanks.
So before I made that statement, I'd said around life expectancy is about the same. So if we look at people, the average age for, I'll use again South Africa, was about 41 for women. Now we've gotten it up to 68, right? We can't just look at getting to 68. Are you in good health when you get to 68? Can you move your body? Are you disease-free? So people living with HIV have got 16 fewer good years in good health. Yeah. No, due to all those diseases that I listed, cardiovascular disease being the top one. Okay. So, hand over to you, Francois.
Thanks, Nomathemba, and thanks for attending this late hour. So let me just get our slides up. So what you may not appreciate is that obesity and HIV medicine is one of the burning areas all of a sudden. So we've moved from this quite bizarre dichotomy across the world, but it's become a big public health issue in HIV, which you've got these almost two extremes. You've got people coming in very late, who are in various states of denial, coming in with classic AIDS, and still a massive problem in South Africa. Our hospitals are still clogged with people with very advanced HIV, coming in with the classic AIDS-defining illnesses. On the other hand, you've got people taking their treatment who are gaining weight hand over fist, for which we have very, very few options available to them. So it's a very, very bizarre situation we're stuck with, and a very complicated situation from a public health perspective. Just waiting for these slides. And I've had to kind of retrain myself in many ways to try and work out what we're going to do about this. And I've been quite struck at how remarkably similar the epidemics are in terms of things Nomatema was talking about in terms of stigma. Thanks. These are my various disclosures. And it really has been a lot of my work, which is to try and find ways to actually understand this. And it really does feel like HIV in 1997, where we're trying to muddle our way through the physiology, try and find ways even to define obesity. There's such a big fight within the obesity world. And if you think HIV people fight, you must watch obesity people fight. But it feels we've got all these drugs, we don't really understand how to use them, they've got all these side effects, we don't really understand either, and we're just really trying to muddle our way through with this huge epidemic we faced, and we don't really know how. So the HIV story is important to understand. This endocrinologist, who is probably known to many of you, told me this last year, that treating diabetes is hard, treating HIV is easy. Now he was talking about HIV, diabetes in its entirety, and you may not know, I came from the diabetes world into HIV just before this. And it was really irritating. He was just sort of dismissing HIV. And he's right, it is really, really easy to treat HIV now, but it was hang of a lot different in 2003, and I'm not going to take you through all of this, but we used to take 2 tablets in the morning, 3 tablets at night. You used to have to titrate according to person's sex, according to their pregnancy status, according to their CD4 count, according to the viral load. You had to do different kinds of monitoring. Treating HIV in 2003 was a hang of a lot more difficult than treating diabetes. And we have made it easier because we worked hard at it. And and a lot of what I think is going to need to happen in obesity is we're going to have to work very, very hard to make it simple. I'm going to talk a little bit about the drugs, and I think there's a big challenge waiting for us in primary care for what we're going to do to that. The other thing is that, Nomatemba touched on this, the area of stigma for me is, once you've been through the HIV world, you've kind of had to watch your P's and Q's, and then moving into pronouns has been really easy. Wait until you get torn a strip off you by the obesity activists. Again, there's a whole area of waiting for those of you going into this world where you do have to start understanding the language we very casually use, particularly in medicine, and how much harm you cause and hurt you cause without realizing it. And I remember, many of us lived through this period. Diana, shaking hands with HIV positive people without gloves, and what a big deal that was in 1983, 82. And you think how ridiculous that sounds now, but how important those kind of things were in that day. I think the other thing to remind ourselves, just less than 20 years ago, 1,000 people were dying a day in South Africa, and lots of brave people were involved in fighting for ARVs. And Nomatemba pointed out that we had to fight against a denialist government and a whole lot of really bad actors in our country. And weirdly enough, once Zuma took power, he swept all of that stuff aside, and now we have a world-class ARV program. And there are lots of problems with the ARV program, make no mistake, but we have somewhere between 5 and 6 million people on ARVs, which people are swallowing in Melbourne, they're swallowing in London, they're swallowing in New York, the same drugs that we are using across the public and the private sector in South Africa. And with it, South Africa's life expectancy went up. Since the ARV program, all the impediments that started to happen between 2004, 2008, sort of were swept away. Life expectancy, that big dip you can see there is obviously COVID. But it's been steadily getting better because we got more and more people onto antiretrovirals. And it really is a massive public health success. But it's also important to remind ourselves that the drugs had lots and lots of side effects before 2008. And for those, again, the clinicians in the room who actually were around there will remember that we were able to dispense the drugs, but after about 6 to 8 months, some of these drug side effects would start declaring themselves. And they declared themselves sometimes in big headlines in the Sweaten, but often they were really scary side effects like hyperlactatemia, things with very, very high mortalities, very stigmatizing side effects where people would lose fat in their faces and in their bodies, where you could tell somebody was on antiretrovirals just by looking at them. So this is a study Nomatemba and I were involved in to test a new drug called dolutegravir. And I'm not going to bore you with the minutiae, but this drug came along in about 2013, 2014. It's part of a class of drugs called integrase inhibitors. And it's come to now, just to give you an idea, pretty much 90% of the world is now on this drug and the combination of this drug. And we were going to bring combinations of these drugs, taking WHO guidelines to give them the evidence base so the Department of Health could move this into guidelines, and WHO could move it into guidelines, and it was a huge public health success. So we took people from the streets of Hillbrow, essentially, and randomized them to this huge clinical trial run out of a shack in Yeovil, for all intents and purposes. And the regimen's in the middle there. And again, I'm not going to bore you with the details because you're probably not interested. And if you are interested, you can come and get the paper from me. And we ran it's a classic old-fashioned clinical trial. There's nothing special about it. And the regimens actually all did well, including the old regimen that everybody was on, the regimen at the bottom in green, the efavirenz-based regimen. They actually did really well. But the study came out, and there was huge fanfare about it. But there was one tiny thing that happened, and I remember Simiso Sokela, is the doctor who's the co-PI on it with me, said to me during the study, she said, in fact, she didn't say our patients are gaining weight. She said, and Simiso is very much a straight talker, she said, they're all getting fat. And I was like, yeah, like just turning back into South Africans, it's fine. I've got lots of other things to worry about. Please leave me alone. And she's right. They were turning back into South Africans. And when we presented the data at one of the big AIDS conferences towards the end of 2019, this electrified the whole of the HIV community was how much weight people were gaining on these new regimens. And you can see 10 kilograms. And people say, oh, they were just getting healthier. Our patients actually started with really good CD4 counts. The average CD4 count was over 350. And particularly women were gaining weight, and they were gaining weight fast. We had people going from a BMI of 24 to a BMI of over 60. So people were gaining, in some cases, incredibly large amounts of weight. Initially, we thought it was the drug's fault, and there was some very elegant PK stuff done by Pumla Sekgabi and Gary Martins here at UCT. And they demonstrated that certainly it did not seem to be the dolutegravir's fault. There's been subsequent data suggesting that this class of drugs actually might be more complex, and there are other areas of weight gain being debated at the moment, which we can talk about, but it wasn't primarily. There's something about that HIV seems to be having an impact on either on the fat tissue itself, disturbing the metabolics of it, the hormonal area, or the hypothalamus, which is where the anti-obesity drugs actually act. So you can ask yourselves, you HIV clinicians, like, what were you doing all this time? Like, why did you not notice this weight gain stuff? Like, why? And the interesting thing is the registration studies, not just for dolutegravir, but for all the new antiretroviral drugs, were predominantly done on white men. And you'll be shocked at this, probably not that shocked. I just was horrified. We did this paper looking at all the registration studies. It hasn't changed either, by the way, since we published this study. Of all the major breakthroughs in drug discovery of the last while, they were predominantly done on white males. And that's the group where we see the least amount of weight gain. The group where we see the most weight gain is in black women, who are grossly underrepresented in these registration studies. So people often come to say, you mustn't use guinea pigs in Africa. Africa is grossly understudied when it comes not just to drug studies, but in studies in general. We should be doing far more research in the continent than not, because this is how we end up. We end up finding out about side effects and things after the fact, when we should be actually finding out in the context of actually exploring these drugs in more real. Anyway, so antiretrovirals are marching on merrily and doing very, very well, and we are moving into this area of long-acting injectables. Many of you have seen the stuff that Linda Gale Becker put out, this amazing new drug called lenacapavir for prevention. We've got all these other injectables. It's a very exciting field. So ARVs march on. People like me are dealing with like the consequences of obesity, and I'm going to talk about that at the moment. And there's some really brave African researchers taking forward this agenda, which I'm thrilled we're all part of. Same though in obesity. The drugs, as I said, I feel like I'm back in 1997, but the drugs are revolutionizing things. Now, you heard from Nomatemba, but I think we all know that there are associations between obesity and a whole range of complicated things, ranging from cancer to poor pregnancy outcomes to diabetes to hypertension, you name it. It's quite a bewildering range of stuff, and the reasons for it are quite complicated as well. As I said, the definition of obesity there's a big debate about it, but as your weight gain climbs, your risk of all of these conditions climbs with it. And those associations are every bit as strong as the associations of, say, tobacco with lung cancer. The good news is that you don't have to lose much weight to reverse them. These are some of the conditions going down there. PCOS is polycystic ovaries, GERD is like reflux. NAFLD is the old name for fatty liver that Nomatemba was talking about. But you can see just losing 5% often will take care of a lot of the problem. Losing 10% in most cases will take care of almost all the problems. So that's great news. So we don't have to lose much weight. The problem is it's almost impossible to lose 5% in the long term, even in the medium term. And this study, which was published quite a while ago in the NEJM, looked at just where lifestyle conditions. Lifestyle will allow you to not gain further weight, or it will modify that trajectory. So it's really important. We all should be doing the lifestyle stuff. It doesn't matter what your weight is. You should be eating properly and you should be active for your own health and for all sorts of other reasons. It will not help you lose weight in a sustainable way. All the diets help you lose weight in the short term, but there's a lot of evidence that you actually get rebound gaining weight. And in fact, there's a lot of worrying of all the stuff I was taught as a medical student about exercise and diet actually makes the problem worse. So the thing we get taught is the major reason to help people with obesity, with established obesity or overweight, actually makes it worse. So this is a real, the problem is that in 1 or 2% of people can do that. And they're the ones who write textbooks, they go on television, they won't shut up at the dinner table, and you must be like them. The rest of us cower in fear and the hatred of ourselves and shame because we can't be like them. And it's all about, oh, if we could just control our appetite. But the problem is that there is a world of physiology evidence to suggest that your body is going to actually even physically lower the temperature to try and preserve those calories. So you're not able to lose weight. It's almost physically impossible. Your body is going to be fighting. It's not just hunger mechanisms, but even basic physiology mechanisms. And then people like me in my profession collude to make money off this by selling snake oil. And then we have all our own snake oil peddlers locally and internationally. And lots of people make money out of this. It's a billion-dollar industry. I mean, within about a square kilometer of here, there's about 4 gyms who are all just wanting you to come and be members. And as I said, they just make you feel horrible about your body. And these kind of body shape things are linked to all sorts of poor outcomes, including poor mental health outcomes. So there's a lot of introspection that needs to go to the medical industry, firstly for peddling really bad medical advice, but also colluding in all of this. Every single GP I go to is flogging some snake oil weight loss supplement. But luckily we have lots and lots of these new drugs coming onto the market, and I am astonished at how effective they are. They all have the issues. These are just the new injectables, and if you've been living under a rock, you won't have heard of semaglutide or Ozempic, which every movie star seems to be on at the moment. This is for diabetes. It's not registered for weight loss. It's underneath a different name. But there are a whole of these others which are being in various stages of development. I mean, it's a drug company's dream, you can imagine, to be able to sell these drugs. And there's this pyramid of which is the old obesity pyramid. It reminds me of the old food pyramid of interventions. Right at the bottom, you can see the lifestyle stuff, which is kind of temporary, with a bit of overshoot. You've got the nutritional interventions where you actually give food substitutes, which are actually quite effective. Then you've got the pharmacotherapy where you can lose, some 15-odd%. Then you start using these endoscopic banding procedures where you can get up to about up to almost 20%. And then you start chopping chunks of the stomach out and surgery, which actually has come a long, long way and is very effective, where you can get up to as much as 40% weight loss. And these drugs start working in different ways. There are certain classes of drugs that work more on the periphery, but most of them seem to exert most of their effect on the brain at various points, as I said, of the hypothalamus largely. And they seem to inhibit areas of craving. So you essentially just take hunger away. You don't necessarily take away enjoyment of food, although you'll see lots of case reports in the literature about how somebody just, it's like eating in gray when I used to be eating in color, and quite a lot of dramatics. I must say, Nomatemba and I use a lot of these drugs, and we don't see that. We see people just eating much less and feeling much more in control of their food environments, but they still enjoy their food. And this list of new agents, as I said, they can't find enough clinical trial sites to actually test these across Europe and North America because there are just so many drugs available at the moment. We don't know how long you're going to need to take these drugs, whether they're permanent, like a hypertensive. Obesity tends to be progressive, so it might well be like hypertension or diabetes, where you're actually permanently on them. We don't know the side effects of the newer agents. Semaglutide, actually, we've had on the market for a long time, so we actually have a good sense of the side effect profile of that drug. We don't know, some of them are injectable, some of them are oral, some of them have to be titrated, so they're quite fiddly. And they cost, many of them cost an absolute fortune. Semaglutide's about 6,000 Rand a month. It's double that in the US. The medical aids are freaking because if you give it to 31% of people in South Africa, we'd just crash the entire economy overnight. So that we need a strategy for dealing with this. And this is exactly the same as HIV. They cost an absolute fortune at the time. So the food pyramid and obesity pyramid is actually now changing because the drugs are now starting to make you lose between 25 and 40% of your weight in 1 year. So it's getting closer and closer to that surgery area. As I said, there are lots and lots of questions around the drugs, but there are questions around the surgery as well. And the problem with surgery is even, that's very effective. There are not enough surgeons. There's just, even in the richest countries in the world, there's a queue a mile long and they can't get enough surgery through the door. So this is not an option in the richest place in the world. It's not going to be an option for us. We've done lots of work on the costing of these obesity agents. We did this for HIV, we've done this for hepatitis C, for the TB drugs, and we've shown that they can be manufactured at a fraction of the cost, which comes as no surprise to any of you. This is just price gouging by the drug companies as usual. And we do need to try and find a way to actually get the prices down in a way that makes the industry sustainable. And but at the same time makes it broadly available. But as I said to you, these drugs are fiddly at the moment. This is not something you hand out to a primary healthcare clinic and say, have at it. These are not like antihypertensives and diabetic drugs at the moment. They are, as I said, they really remind me of the ARVs of 1997. The interesting thing is these drugs are now expanding in terms of the indication. They're starting to be used for kidneys, for liver fat, for a whole lot of other, for heart failure. And they start to show interesting things on other areas of craving, everything from alcoholism to opiate addiction. The problem is we can't do the studies because the drug companies won't give us enough tests. You can imagine another area of medicine's failed at is treating things like alcoholism. Even for gambling addiction, it's been shown that people on the obesity studies, if they drink less, they gamble less, they do all these other things. So there's something about craving that's really interesting for us to think about. So we've got these two new epidemics causing huge costs to the community. And Nomathemba talked about this rise in, as the GDP grows, sorry, I don't know about the HIV status of these politicians, but I think that as the GDP goes up, certainly in our region, people start getting bigger, and particularly women. And you can see this data from South Africa, how stark that is as people move up in terms of the economic status. And there's been work done at WITS that's demonstrated that they estimate that over 2,500 Rand per South African is the cost of the obesity epidemic at this point. And it's probably just going to get bigger and bigger. When I went and met with Discovery, they told us that type 2 diabetes consumes 1/3 of their entire budget. HIV is like a rounding error for them. They were not interested to listen to me about my HIV problems. But as I said, the science is evolving. We don't understand what a healthy diet is. We do know that what is an unhealthy diet is these ultra-processed foods, these additives into what we're eating. Everyone's on about the Caribbean diets and the Banting, goodness knows what, all in the South Beach diet and everything else. Probably some sort of unprocessed diet with less and less sugar and fat and stuff added to it is probably the way we need to go in. But that has been what's changed. I think what I found fascinating is that the obesity epidemic, at exactly the same time in South Africa and across the world, mirrors a pet epidemic. And it's probably suggests to me that this is related to the food supply. I mean, you're the epidemiologist, you can tell me, but it really, when they started to sell processed food for our pets, that's when they started to see this happening in there as well. Again, prevention is very, very complicated, and there's a lot of, when you ask anybody in the room and you ask lay people and you ask doctors and nurses, they all go on about how people are obese because they're lazy and they put anything in their mouths and they'll eat anything and blah, blah, and it's a terrible narrative about that. When you talk to obesity experts, it's all about the environment. It's all about the genetic backgrounds, about the food in front of the choices that people get forced to make. It's not that there's no volition, but it's the same as HIV. we did some work here looking at HIV, and she talked about, Jen Cohen, who's at the University of Miami, talked about like the HIV epidemic and stuff, and about the kind of intersection of things like poverty and that. And she said, it's capitalism. That's why HIV is so bad. And you have to talk about things like that. Drug side effects are actually a tiny part of HIV. And Jeff Wing, who trained Norman Timber and me on how anti-obesity drugs, talks about this as well. He says, you would choose your parents wisely. It's such a genetic thing. And you think about when you were growing up in the food environment that you grew up in. We did not have donuts available to us. We did not have Coke available to us in the way that we have now. Almost done. And this was just a very sobering thing for me, is there's not a single country that's reversed its obesity epidemic yet. You'll hear people talking about Japan and France. It's better there, but they've got escalating obesity levels. And Norma Timber talked about this. Same as HIV, we've got a government in complete denial. Like, they don't want to tackle the food industry, they don't want to look at safe food, they don't want to, it's just too hard. And there are so many vested interests within that is important. I was struck by this quote from Edwin Cameron around HIV, just talking, I'm not going to read it, but just talking about how, you know, at the time in 2003, 2004, those of us who were able to get HIV care, it was expensive, but we were able to get it. I was looking after very influential politicians who were sitting in the cabinet denying it to poor people. And what's interesting now is we've now got a whole coalition, including people from the Treatment Action Campaign who were involved in the original HIV advocacy, get involved in fighting for safer food supply. And we saw a terrible thing between prevention for HIV and treatment for HIV, where prevention people were saying, you know, we can't treat them, it's too expensive, let them die. And we can't have that with obesity. We can't have a situation where we say, you don't need to treat them, we must sort out the food supply. We need to do both. You need prevention and you need to have treatment. So just to finish up, how are HIV and obesity similar? They're both very common, they're very complex, they're hugely important. They're both preventable and they're both going to need government intervention. You know, we cannot let the food market continue the way it is at the moment. They're both highly dependent on external social, societal factors. Black women are incredibly vulnerable to both, and it's something that really is stark when you look at the numbers. You know, all sectors of society are vulnerable, much like with HIV, but black women in particular bear the brunt of it. There's a huge amount of stigma and blame that still go on, and just watching social media and the unpleasantness around that is horrifying sometimes. The new drugs are transformative, but they're complicated, and we're going to need. And finally, we're going to need a delivery system for obesity care, and we have nothing of the sort at the moment. There's this vague idea that there's going to be health messaging out there, but we're going to have to deliver these drugs at some point, and we don't have that system in place at the moment. Thanks very much. Sorry I went over time.
Are there any questions for Prof. Venter before we move on to our last presentation? Yes, please go ahead.
Thanks. Of decreasing obesogenic environments. Do you think that could influence the sort of the obesity epidemic? Just because, you know, we're all just bombarded with all these fast food options and convenience and tasty and all the rest. I don't know if there are any case examples.
So I totally agree with you. This is where government has to get involved with legislation. But the fight back from the food industry has been, even around the sugar tax, has been huge. I mean, I've just watched on Twitter how they've bought off cooks to say, oh no, sugar is normal part of your diet, you know, you must just have it. And the kind of, like we've been involved with Gila and just watching the kind of food labeling, which is the lowest level you could see, but the amount of pressure on government to delay putting that out there has been significant. If we start saying things like I don't understand why these people are allowed to sell the stuff at schools, like people are not petitioning against it. There was a study in Nature that said that the amount of sugar people eat in America is the same as smoking 20 a day, the impact on health. Imagine if we go at schools, at children's birthday parties and start handing out cigarettes instead of cupcakes, how the parents would react if they saw this data. And that's the kind of thing that I think public health people need to get much more stuck in. There was a public health conference here last year, I understand, where they were giving out free Coca-Cola. and people had to get stuck in and say this is not actually okay anymore. There's been petitions to try and stop people selling soft drinks at medical schools and things in the same way that we don't sell cigarettes there anymore. So I do think these kind of things need to happen, but understand that the vested interests to stop this are huge, and then you get accused of nanny statism and all the other stuff. But it's going to be hard, whatever we do.
Yes, Landon? Oh. Okay.
Ozempic has refocused and energized some of the attention, refocused attention and energized us. But is it realistic to think that we're going to use drugs to manage obesity the way we manage HIV? And here maybe some of the parallels between an infectious disease and a chronic condition fall out. And I'm just interested in your thoughts.
So my simple answer is no. I don't think we can treat our way out just because of the magnitude of the problem. And two, these drugs don't work in everyone. So even in clinical trials, 10 to 15% of people are non-responders. We're not quite sure why. Maybe the dosage is a bit low with these new drugs. We do need probably higher dosages and better concentrations of them. And then the last thing is that because obesity is multifaceted, our response has to be the same way. So can't think of any other disease that we've treated our way out of, HIV being a prime example. Even when the drugs are available, even if they're at good cost, we still have an issue. So, I mean, if you think about key populations where we are not able to reach them with everything that we have available, it would be the same thing with obesity. I don't know if you have a comment.
Yeah, I agree. I think that if you, maybe to be controversial, I think HIV's treatment program has been a huge success. I think our prevention program has not been a huge success. I think it's been a chaotic, throw some circumcision there, throw some condoms there, and hope it all falls down, everything comes down. We still don't, incidence has come down, but I'm not convinced that it had, I think part of that was just a natural incidence decline. I think, circumcision and condoms had some, how much behavior change had, it's anybody's guess. So I think there has been incidence reduction, but it hasn't been this concerted, firm thing that's been done. And I don't think the ARVs have had a massive impact in terms of treatment. And treating somebody with obesity doesn't have the knock-on effect that you have as you have with HIV. So I don't think it's going to be a quick get-out-of-jail card. I also think addressing the obesogenic environment is actually much, much harder than dealing with HIV. So I think whatever we do is we are setting ourselves a bar that is high. Having said that, it tackles things like poverty, hypertension, diabetes, a whole range of other stuff. So it's kind of something we probably should be thinking about already. And I do think that there's something about food that we do need to be thinking about more broadly in terms of health. It always staggers me that the Department of Health team seems to think like food isn't something we should be thinking about tackling. It goes to social development or to somebody else in the clinical situation. And to my mind, it's such a fundamental part of people's health that we should be thinking of integrating much more into the health sector.
So with that, over to you.
Perfect. Thanks so much, Amber. So I'm Ornay. I have the honor of chatting to you today about HIV and the cardiovascular system. I'm presenting on behalf of Professor Ntobeko Ntusi, who's unfortunately unable to be here. He's recently taken over at the home of the South African Medical Research Council, and he expresses his heartfelt apologies in that regard. I've been a part of his research team now for 3 years, principally looking at imaging related to the cardiovascular system and how HIV affects the cardiovascular system within this domain. So I'm going to be touching on quite a bit of research that he's done over the last 2 years. And just a brief overview of what I'll be speaking to. It's going to be quite jam-packed, but I'm trying to cover all segments of the cardiovascular axis and the way in which HIV affects the cardiovascular system. So just a quick recap. I know you've dipped your toes into the epidemiology. At the end of 2022, there were 38.4 million individuals with HIV. just under 70% of which reside in sub-Saharan Africa. And with the rollout of antiretroviral therapy, mortality has decreased substantially. We haven't yet met the target of rolling out ART to 30 million individuals, but the hope is there that we'd be able to eradicate AIDS by 2030. Looking more specifically at the cardiovascular system, we know that HIV is associated with cardiovascular disease, and that it's present in up to 10 to 20% of hospitalized patients with HIV infection. What we also know is that it can affect every segment of the cardiovascular axis. And individuals used to come in with florid myocarditis, inflammation of the heart with overt systolic dysfunction in heart failure. And that era that was pre-antiretroviral therapy era. And now the epidemiology has changed slightly, and the symptomatic myocarditis with florid heart failure it tends to be a thing of the past. And there's a lot more subtle, subclinical, preclinical diastolic dysfunction with heart failure with preserved ejection fraction. And so the phenotype has changed. What is contributing to this increasing disease burden? So there's this continual growing of the HIV population, new infections, but also individuals are living longer. They're no longer dying of age-related illnesses, of opportunistic infections. They're living into more communicable diseases, and that interplay becomes a lot more important. A study that was done in 2016 evaluated the stage at which individuals are entering care within South Africa. I think they included just under 650,000 participants. And what they found is that up to a third are entering care quite late in the disease process with CD4s less than 200. And 17% are entering care with CD4s less than 100. So there's this late diagnosis. The disease has already had time to manifest in the cardiovascular system and all other organ systems. Individuals are also quite disengaged from care. There was a study coming out from Khayelitsha locally here, also looking at a large number, I think 40,000 odd, and just under 1/4 of individuals were deemed to be disengaged from care, not continuing with the treatment for more than 180 days or not following up during that time period. And then finally, adherence problems and delays with switching to second-line antiretroviral therapy. At the moment, nationally, we're sitting at around 4 months odd. There was a study done in eThekwini to evaluate how they're faring relative to the rest of the country. And the time between confirming virological failure and going into second-line antiretroviral therapy, there's this long delay. So yet again, the disease and the viremia has time to manifest within the cardiovascular system. There are a number of epidemic drivers in sub-Saharan Africa. New infections, if we look just at new infections, there's poverty and social circumstances, age disparities, sexual partnering, transactional sex, multiple concurrent partnerships, gender-based violence, mobile populations, and interestingly, vaginal microbiome and inflammation, which we'll touch on a little bit later. When we look at HIV-associated cardiovascular disease specifically, these epidemic drivers, the success of antiretroviral therapy has prevented individuals dying at a younger age, but like I said, they're living into these disease processes. And the duration of antiretroviral therapy also plays a role, and we'll touch on that later, how antiretroviral therapy is impacting on the cardiovascular system. There's this aging population of people living with HIV, vertical and fragmented health systems, this epidemiological transition, lifestyle and urbanization and obesity and other traditional risk factors that are compounding the effect that HIV has on the cardiovascular system. So when we speak about HIV-associated cardiovascular disease, it's not one defined entity. Previously we thought, AIDS cardiomyopathy or HIV cardiomyopathy, but as you see here, there's this interplay between various disease processes plaguing, and it's not necessarily HIV driving them. It might be HIV contributing to them, and we'll see it, and we'll touch on some of these, how it interacts with coronary artery disease, metabolic syndrome, dyslipidemia, valvular heart disease, etc. The pathophysiology is multi-pronged. There is direct HIV infection that causes, it tends to affect the myocardium in a patchy distribution, and what we've seen in medical imaging is that the fibrotic deposits as a result infect the myocardium in this patchy type distribution. There's the toxicity of antiretroviral therapy and its effect on the heart and the cardiovascular system, opportunistic infections, myocardial inflammation, HIV-associated nutritional deficiencies, malignancies, wasting syndromes, autoimmunity, capillary leak syndrome, and abnormal coagulation. So it's multi-pronged and it's difficult to pinpoint. And what makes this quite challenging is that there's no particular way in which, there's not one way in which to try and tackle management of this emerging disease entity. So CMR stands for cardiac magnetic resonance, and it's essentially cardiac MRI, MRS, magnetic resonance spectroscopy. I'm particularly passionate about this. This is my bag. This is what I'm comfortable chatting to, but I'll limit it to one slide for you. And what we found consistently over the years of imaging the heart using cardiac MRI. So cardiac MRI is superior to imaging modalities that use radiation, CT, contrasted CT, as well as echocardiography, in that it's not impacted by body habitus. You get temporal resolution is a lot higher, spatial resolution is high, and one aspect that distinguishes it from other imaging modalities is that you are able to get this virtual histological assessment of the myocardium by looking at the little changes in the magnetization of the tissue. And from that, you are able to infer what disease processes and the distribution of that disease process within the tissue. So what we found in imaging is that individuals infected with HIV tend to have a lower longitudinal function, impairment in systolic and diastolic dysfunction. So when their heart is contracting, it's impaired, and when it's relaxing, it's not relaxing to the extent that it should. There's increased focal fibrosis and diffuse fibrosis deposits within the heart. So after the heart gets inflamed, fibrous deposits happen within the muscle of the heart, and as a result, the muscle doesn't function the way that it previously did as a result of these fibrotic deposits. Further to that, it might result in aberrant electrical signals going through the heart, and you might have arrhythmias and other issues related to that. ECV values have been higher, another surrogate for fibrosis. There's been shown to be increased fat deposition within the heart tissue, and then there's higher serum triglycerides, and this is predominantly as a result of antiretroviral therapy, and a high frequency of pericardial effusions, as well as high T2 stir signal intensity ratios, which is a surrogate for edema within the heart muscle. And this shows us that there's this chronic grumbling inflammatory process. So, and this is all in comparison to uninfected individuals. And it's postulated that this chronic subclinical inflammation drives fibrosis and drives this diastolic and systolic dysfunction that we are seeing. So as I said previously, this entity of florid myocarditis and heart failure that was prevalent in the pre-antiretroviral therapy era has slowly changed over time as new drugs have come into play and as treatment regimens have changed. And this has been phased out with this diastolic, this more subtle diastolic dysfunction becoming the predominant picture. And what we see is a heart failure with preserved ejection fraction. And so often individuals won't know that they're in heart failure because their heart is still pumping adequately until there's a trigger and it just no longer is. And that by that time, the disease process in the heart is quite advanced. So speaking to heart failure specifically, I've touched on the myocardium. Previously, in sub-Saharan Africa, a review by the late Professor Bongani Mayosi and Professor Ntobeko Ntusi assessed the main drivers of heart failure within this region. And the top three causes were hypertension, cardiomyopathy, and rheumatic heart disease, with HIV only accounting for less than 5% of causes. 4 years later, the Heart of Soweto study found that just under 10% of individuals presenting to Chris Hani Baragwanath Hospital in Soweto, that covers a population of just over 1 million, up to 10% of them were presenting to the cardiology unit for various cardiovascular related issues. Up to 10% were HIV positive. And of those HIV-positive individuals presented in heart failure with that myocardial dysfunction, that's cardiomyopathy type picture. But the reason why this pie chart is, I've extracted this pie chart from that paper, is to show you the other side of the pie chart, the non-blue, where the various different segments of the cardiovascular axis are impacted by HIV. And I'm going to draw on some of those going forward. So an analysis of 25 studies from Africa, Asia, North America, and Europe confirmed that between 2000 and 2018, there was a nearly twofold increase in heart failure in those that are HIV infected versus those that aren't. And this association persisted with or without coronary artery disease. And risk factors for heart failure in HIV included elevated viral load, low CD4 counts, presence of traditional cardiovascular risk factors, and interestingly, female sex. So what has antiretroviral therapy done? Antiretroviral therapy has been shown to modulate these myocardial abnormalities that I've alluded to. And so when compared to antiretroviral therapy naive HIV-infected individuals, those on treatment have reduced level of systolic and diastolic dysfunction, reduced myocardial strain, less fibrosis, and less edema. And in a study conducted close to home within our unit, what we found was that adolescents with perinatally acquired HIV who are on antiretroviral therapy have reduced left ventricular remodeling compared to those who are not on antiretroviral therapy. And this remodeling is essentially the changing of the myocardium as a result of that lymphocyte infiltration and the various changes afflicting the muscle. So I think what you can gather is that there are multiple disease processes that essentially go and drive these mechanisms, these mechanistic drivers that bring about these pre-heart failure phenotypes that ultimately culminate in heart failure. And this is just a nice image reflecting that. And I'm going to be speaking to some of these other disease processes, speaking to vascular stiffness, and thrombosis and dyslipidemia, and the way that these contribute towards the culmination of heart failure. So ischemic heart disease in HIV. So there's an increasing impact of atherosclerotic heart disease on morbidity and mortality in HIV relative to the previous AIDS-related diagnoses. And in the global north, cardiovascular disease is becoming the leading cause of morbidity and mortality in HIV-infected individuals. The DAD study, the DAD study, found that the risk of myocardial infection and coronary artery disease is increased in patients living with HIV, and the incidence of myocardial infarction increases with the duration of antiretroviral therapy use. So it's almost essentially a bit of a double-edged sword. You damned if you do, you damned if you don't. I mean, there are cardiovascular ramifications of having HIV infection related to the extent of the viremia and untreated HIV. But at the same time, if you take antiretroviral therapy, you're increasing your chance of having a myocardial infarction. And on the top right there, there's a lack of the bottom axis there. Apologies for that. The bottom axis represents the years on antiretroviral therapy. And that graph is just showing the increase in incidence over time with extended antiretroviral therapy use. And this increased risk is beyond that is predicted by normal traditional risk factors for ischemic or atherosclerotic heart disease. And this positions HIV essentially as its own risk factor. And I heard that from one of the previous sessions, one of the presenters alluded to the fact that from the Reprieve style, which is this multinational study incorporating 7,000 odd individuals looking at the effect of HIV on cardiovascular outcomes, that they might be deriving a new calculator that takes into account an individual's HIV status. So what we know from the research is that HIV confers a 1.5 to 2-fold increased risk of ischemic heart disease, and that this specific risk varies according to sex and virological status. And then as we see at the bottom there, the relative risk is 2.18 8 odd. I can't see it from here, sorry. But that's independent of the other traditional risk factors indicated above. So the addition of having HIV is just cumulative. Individuals also have other traditional cardiovascular risk factors, and as diseases of lifestyle and obesity and other risk factors become more prominent, the amalgamation of it can become quite catastrophic. And whilst we know specific antiretroviral therapy increases cardiovascular risk, the net effect of antiretroviral therapy with its viral suppression is beneficial with regard to overall cardiovascular risk. We also know that HIV perturbs plasma lipids, and in an analysis of just under 14,000 people living with HIV, the pooled prevalence of moderate high cardiovascular risk through random effect modeling was as high as 20.4%. And the most prevalent concomitant cardiovascular risk factor is dyslipidemia. And dyslipidemia, we know, is a key driver of atherosclerotic heart disease. And this REPRIEVE trial that I spoke about earlier has found that consistent use of lipid-lowering therapy in HIV-infected individuals, particularly pitavastatin, has been showed to lower the risk for major cardiovascular events by 35% and to lower mortality by 21%. So there's evidence to show that initiating patients on lipid-lowering therapy may reduce their overall risk. The infographic on the top there is from the trial, and what you see there is, in fact, in untreated individuals, there's a bit of a dip in total cholesterol, LDL, and HDL, and with commencing on antiretroviral therapy over 10 years, that risk increases beyond the baseline of that when individuals are uninfected. So we found fat in the blood. We've also found fat within the muscle of the tissue, and these studies are based on that magnetic resonance spectroscopy imaging modality. And this is a study that also based off the REPRIEVE trial, a cohort of 172 that looked at the extent of myocardial and hepatic steatosis, intramyocardial lipid content. And what they found that apart from the traditional risk factors, HIV presents its own risk factors, and individuals living with HIV have got a higher prevalence of, or are more likely to have steatosis, myocardial steatosis, and hepatic steatosis. And some early results from studies conducted within our setting in perinatally acquired HIV are rendering similar results. There's also fat around the heart, not within the heart. So pericardial and paracardial fat content has been shown to be associated with patients, and is greatest with patients living on patients with HIV on antiretroviral therapy. It tends to have an intermediate phenotype in patients with untreated HIV, and then is lowest in HIV uninfected persons. The other myocardial abnormalities persist, and this is all based off a master's thesis done locally here through the University of Cape Town. Finally, moving a little bit away from the heart itself and the plumbing leading to and from the heart, HIV is also known to be associated with vasculopathy. Thickened vessels, thrombosis, and aneurysm formation tends to be the predominant phenotype, and this is related to this lymphocyte infiltration, mucopolysaccharide deposition in vessel walls, and plexiform changes. And it increases your risk of stroke. Whether or not it's directly related to HIV or through indirect means, we know that the mechanisms of HIV-associated vasculopathy, opportunistic infections, cardioembolism, and coagulopathy all increase your risk of stroke, and HIV is implicated in all of those drivers. HIV vasculopathy describes various cerebrovascular changes, including, like I alluded to, stenosis and aneurysm formation, vasculitis, and accelerated atherosclerosis. And antiretroviral therapy is clearly beneficial, but it can be erythrogenic because it's increasing the amount of circulating fat in your blood and may increase your stroke risk. Although the odds ratio is reduced if you are HIV positive and on antiretroviral therapy. What we see in the picture there, on the top is essentially an occluded left common carotid artery, as well as vasculopathy of the middle cerebral artery. In the middle there, that's from a CT angiogram, a 3D rendering showing us this fusiform dilations within the circle of Willis, the aneurysm formation as a result of HIV. And at the bottom there, histology and H&E stain showing that intimal thickness, interruption of the internal elastic lamina, neutrophil infiltration, and surprisingly an absence of atherosclerotic plaque. HIV has also been associated with increased pulmonary artery systolic pressures, and there's a large study conducted in the US called the Veterans Aging Cohort Study, and what they found is that people living with HIV have a higher incidence of pulmonary hypertension than the general population, and that this incidence is again reduced by antiretroviral therapy. HIV is also associated with peripheral arterial disease, again the Veterans Aging Cohort Study. So there's this established relationship between HIV and the vascular system characterized by this aneurysm and occlusive disease. And the clinical imaging and pathological observations position HIV as this unique entity in terms of this large vessel disease that we're dealing with. And what was found by the Veterans Aging Cohort Study was that infection with HIV is associated with a 19% increased risk of peripheral artery disease beyond that explained by traditional risk factors. I've alluded to the fact that vessels become stiff and non-compliant, and this has been demonstrated. This is a study coming out from Oxford that evaluated the extent of aortic distensibility and pulse wave velocity, and what they found is that in HIV-infected individuals, pulse wave velocity is higher, and aortic distensibility, the ability for the aorta to absorb pressure, is decreased in HIV-positive individuals relative to HIV-negative individuals. And then finally, just touching on those sex disparities that we tend to find in HIV-associated cardiovascular disease. What's come about in the research, and it's not well explained, and not the mechanistic drivers haven't been completely elucidated to date, but female sex has been shown to be a risk factor for patients living, for heart failure in patients living with HIV. And female sex has been shown to be you stand at 2 to 2.8 times higher risk if you're HIV positive woman compared to an HIV negative woman. And the risk is also higher, it's 1.5 to 2 times higher when compared to men with HIV infection. Among women with HIV, they tend to have high rates of hospitalization, longer hospital stays, and high rates of cardiovascular disease, mortality related to cardiovascular disease compared to uninfected women. We also know that your risk for coronary artery disease is higher for women with HIV, 1.5 to 2-fold higher. And this is in contrast to uninfected population that tends to find the reverse, where men have a slightly higher incidence of coronary artery disease. So as I said, it's not fully explained. I don't know to what extent I'll be able to give you some feedback on if any questions arise to this extent, but it's postulated that this is due to sex-specific responses to the virus and immunomodulatory agents due to higher levels of systemic immune activation. So what has been found is that women who are infected with HIV tend to have higher CD4s and lower viral loads compared to men. But it may come at the cost of this higher systemic immune activation. There are also social and behavioral factors. One of what we found locally is that it's quite difficult to find adolescents with horizontally transmitted HIV. It's difficult to find male adolescents with horizontally transmitted HIV. And we've postulated that it may be as a result of the tendency either for young females to have those age-disparate sexual partnerships, or related to social circumstances where there is this epidemic of gender-based violence. So there are social and behavioral factors that play a role in this. There are also comorbid conditions and perturbations in this hypothalamic pituitary gonadal axis have been postulated as potentially playing a role. And I know there was discussion on menopause and its effects, and the interplay between menopause and cardiovascular disease risk in the setting of HIV. So, you've seen that it's multi-pronged. It poses quite a nightmare in trying to manage it all. And the challenges persist. There's limited understanding of the mechanisms and treatment strategies for cardiovascular disease specific for patients living with HIV. Newer studies suggest that there's the importance of inflammation and immune dysfunction as non-traditional risk factors, and hence essentially risk factor, and HIV is a risk factor on its own. And current recommendations for the prevention of cardiovascular disease in patients living with HIV are non-specific and do not consider the unique pathophysiology of atherosclerosis in this population. So I'm going to end off with a call for action. I think Francois also alluded to it in his talk, and we were chatting a little bit before the presentations, and he was saying there's this decrease in randomized control trials related to HIV within our setting. And it's unfortunate. Africa represents the youngest and fastest growing population and has the oldest and most diverse genome in the world, carrying about 20% of the global disease burden, with scientific output representing less than 1%. So further to that is there's this interplay between communicable and non-communicable diseases that is becoming increasingly relevant and important to study. And there's no lack of world-class facilities and expertise to carry this research further. And so I'd encourage those who have the opportunity to dive in and contribute to this growing body of research that is becoming more and more relevant and only aims to inform the management and better outcomes for patients within sub-Saharan Africa. Thank you.
So I'm going to invite you to sit here with us. You can sit right here. We've had almost an hour and a half. Interesting. Also some things to really think about non-communicable diseases and obesity and HIV in the context of background obesity epidemic. So I'm going to open this up to any questions. We have about 5 minutes left before we all release you to the next session. So please go ahead. I think there's that one.
Hi, I had a quick question around the cardiovascular disease. I mean, this is all new to me, more as a health economist, but just curious, there was a lot of comparison between HIV and non-HIV, or HIV not on ART and then non-HIV, but I'm just curious what kind of risks we see, because so many people are on treatment, HIV treatment now. So is there a lot that's out there on if you're been on ART for a long time, like since inception of infection, like you really haven't had that increased level of prolonged viremia, are you still seeing higher rates of CVD in those individuals as well?
So that's a good question. It's difficult to answer. There's certain disease mechanisms that have more bearing on this high HIV viral load. So when I speak about fibrosis in the heart, that's intimately linked with having a high viral load, less so to do with antiretroviral therapy. So when I look at fat in the heart tissue, that's more linked to antiretroviral therapy use. So there is quite a big body of research that looks at the differences between those that are treated and those who are not treated. That research tends to emanate from our quarters because more individuals are untreated. There's a bigger cohort of untreated individuals. But yes, I alluded to the way in which HIV affects the cardiovascular system and compared, I drew on studies that compared HIV infected versus non-infected. But for the most part, these studies do include an arm of HIV infected on antiretroviral therapy and those not on antiretroviral therapy. And there are differences. I alluded to some of the differences, but I didn't flood the presentation with that. Yeah.
Okay, but there's still, you are seeing differences between someone who's HIV negative and someone who's been on ART
Yes.
for ages.
No,
You're not
so
saying there's still increased risk there with
yes,
HIV negative.
there's still increased risk. It's not as high, but there is still risk. And antiretroviral therapy brings along a new, an added risk as well, independent of HIV.
Thank you.
Thank you. Hi. I wanted to thank all three of the presenters, and this was a great session. And I suppose what I wanted to add was a comment rather than a question, which is in the world of epidemiologists, the study of nutrition is considered like one of the outer circles of hell because you can't really measure it well. There's no objective measure for nutritional intake. And I hope there are no nutritional epidemiologists in the audience, but it is a circle of hell. And the challenge that we've had here today is that there's a macro level high structural problem that's leading, which is around food really, in my reading of this discussion, that manifests in bodies, that leads to measurable, objectively measurable negative health outcomes, clinical and subclinical as you're describing, Mornay. And I suppose the comment is really the challenge to people, the epidemiologists in the audience, to try to create causal links between these things. Because measuring nutritional intake is a nightmare at a population level in sort of a large quantitative study. And yet this is going on. These things are causally related. But to develop an evidence base, a causal evidence base that policymakers will listen to, and then intervention strategies and showing causation in interventions will be the challenge. Because otherwise we'll be left with the nebulous problem that there's obesity and it leads to very bad things in human health. We know what the causes are, but we're having trouble linking in the epidemiologic sense, developing an evidence base linking the upstream causes with the physical manifestations. So I suppose for me, that's one of the takeaways from this is the downstream effects are quite apparent. The upstream problem and developing evidence for the upstream problem is going to be much more thorny in the coming decades. So there's no question there, sorry. But she'll have a question. You're not a nutritional epidemiologist, are you?
I'm not. Thank goodness. Sounds awful. I just have a question, given everything that you all just covered, which was really, really great. When we look at the results of the REPRIEVE trial and you look by region, and I think, Francois, you and I were talking about this a bit yesterday, we actually saw the fewest number of events occur in sub-Saharan Africa and compared to other regions. And I'm curious if you have any hypothesis as to why that might be, why we saw so few events in sub-Saharan Africa compared to other regions.
So Francois is a bit of a naysayer when it comes to REPRIEVE. I also think, like, on the continent, we are seeing a different epidemiology when it comes to cardiac stuff. I think he really laid it out quite nicely. And I actually really like the pictogram where you had the systolic versus diastolic dysfunction. We've got a younger population, mostly female. So I think those are some of the things that we would have to look at. What would be interesting is to do a REPRIEVE type trial in our population. That I think would give probably data that would work best for us. No. Is there something you want to add?
I could just add, so spot on. So the cohort tends to be younger, but also in general, coronary artery disease and ischemic heart disease is not as much of a disease entity within our setting. And so that inherent risk, that underlying grumbling risk isn't isn't the same, and that might account for yeah.
And I obviously agree with that. And I think when you look at the levels of heart failure that you're documenting, taking statins, which is, for those of you who don't know, is what Reprieve did, giving statins, to people with low and moderate risk with HIV, isn't probably not going to make an impact other than on ischemic events. And heart failure probably is linked to the hypertension, the cardiomyopathy with the studies that have been done here at UCT. But I think something Landon raised around food, we are seeing astronomical levels of renal disease starting out in the rural areas at the moment, like in the last 10 years. So this transition, we can argue for more research. And like I was listening to one of the speakers earlier saying we need to grapple with this and we need to be thinking about this. And there does come a stage where we need action to start happening now. We don't need more details to tell us. We got 30% of women in their late 20s with hypertension. Like, how much more do we need before we start tackling the food supply? If we've got diabetics, diabetes is the #1 killer of women in South Africa. These things are actionable things we need to have to happen now. And we may need to make some educated guesses, but teasing out whether it's carrots or tomatoes that we need to be focusing on, we do know that processed food is bad for you, and we need to start maybe doing the stuff we do need to action. What we shouldn't be fighting over is food labels, and that is actually where the level of the fight is at the moment. And it does scare me that government just seems to have no strategy around dealing with this. We need to be tackling malnutrition. That means undernutrition, but also the kind of food environment that we're dealing with at the moment. And poor people have no options, and especially when we worked it out, there's one KFC for every 3,000 South Africans. That's not chicken in Zaman or like any of the other fast food chicken places. That's one KFC. So you can see how the food industry is in there providing very, very cheap, very, very addictive food to our population. And we do not have an advertising budget for raw food. They have a very big advertising budget and lots of lawyers and things to take this on. So we do need to kind of start making some educated guesses in the region, or face up to the fact we're just going to have lots and lots of drugs for people with obesity and all the other chronic conditions.
So with that, I'll close the session. Thank you all for your attention. It's been very informative, engaging, and also quite interesting. A little scary, but it's nice to have this session at an epidemiological conference. I think it is important both for people living with and without HIV. Have a good evening, everyone.